It's sort of like going to the airport, you know, you sort of see all spectrums of.
I don't know.
So these people drive in their Lexus,
I
they've
wasn't
been
clear about
complaining
that.
that they're
I was
medicated.
reading the email.
They got this Rolex watch, and they're complaining that their benefits have terminated. I'm like,
well, I started getting bombarded by these retirement seminars that purport to, make you healthy in your retirement. Within a week, I got 2 different free dinners.
well, knowing you, they know how to get to you, Mike. A free dinner, you're there.
I mean, really, and the interesting thing, 2 different companies, they both have the same strategy, the same breakdown of how you're supposed to have your money all arranged and all this. It's quite interesting. So I'm actually going to go see this guy.
They just pick the better dinner and said, I'm going to go to that one. Well, this one's canless. This is at Burger King. I'm not going for that.
No, they were at Daniel's Broiler.
I figured you'd go to the right
Ruth
dinner.
Chris Steakhouse. Not too shabby.
Yeah. Kennedy, you're still a cheap scammer.
That's right.
Yeah.
You got it.
Well, I don't know. It is. I've had about, I don't know, probably 15 or 20 Medicare Advantage plans. Not one thing came from the Everett Clinic.
Really?
So I said to our marketing office, I said, we have a problem. I said, why is that? I said, because I've had 6 of these from Kaiser, about 4 of these from Regents and Premier, and I haven't seen one thing from the Everett Clinic.
really?
What? And I said, no wonder nobody comes here to sign up, because we don't advertise. Well, we do it online. I said, well, people don't go online. They don't look at it.
That's right.
So they're at the 30-year-olds, their dog's online, not the 65-year-olds.
You gotta get it in the mail and offer them
Oh, I know. But it's
a free lunch or a free
That's right, and it's getting different now, because more of the older people are looking at it. So I handed them this giant package of stuff I heard from other people. And I said, so far the best deal's Kaiser, what do you think about that? And they're like, what? And so you use that for Kaiser?
It's a show that you got.
And they're like,
No, yours is a huge deal.
So it's just, it's a very humorous conversation, but they look totally
I'm not surprised.
because they didn't send me one thing.
I know it's a big deal.
But they did send me a letter asking if I was thinking about leaving the clinic. I said, I'm going to retire. Why would I leave? Oh, yeah, good thing I'm sorry.
Dude, we don't create body heat like you.
But they got all this heat stuff online, but they don't
You
have
create body heat,
billboards. They don't have
okay?
any ads
People
on
don't
anything.
create body heat.
No brochures, nothing. So it was actually pretty something. But those two lots, I do.
No, but we don't have less body fat and we have less muscle to insulate.
Genic fat?
Yeah, then we're gonna have fat. We just have
Are you still working?
Feel my
How
hand.
much longer are you going to go?
I'm sorry?
Yeah, how many years are you going to go?
How's it going?
Too bad. How about you?
Now that I found smart
You're still an Aldo.
I went in
and
and then the thing started
average age
closing.
is about 65. Except for the fellows. Well, I was lamenting that if we
Yeah, so you
don't
gotta wait. Oh,
That's
Tesla.
why I said, well, I'm going to come anyway. So, I've been driving by myself.
I don't buy gas.
You save $100 of gas. One can drive itself.
So, I don't know how we can do production.
You have a place signed up? Not yet.
Oh my god. I saw it. See? Oh, you are so supportive.
So we'll keep getting Mike here.
So I had dinner at a really, really fancy restaurant.
He's just got a free breakfast Sunday night, so he'll be here.
And I'm like talking, and my pinky nail, just the nail, clips into the
You
wine.
don't have to get dressed up.
I know,
Glass
it's a habit, you know.
and all kinds. Look, there's an IV.
Yes.
Oh my god. No, I sent the email too.
You would be here by now.
No, I sent the email.
I don't see Gary either. He's in Robert.
Actually, we did send the email again because I sent the email to you. Oh, sorry, I forgot to send a friendly's email. I totally forgot because it's in the middle of
No, he didn't.
There you go.
Yeah, it's a hardship thing.
Well, he's retired.
But working full time.
I know, he's working more than he ever did before.
I told you I got to stay at Steve's place.
You're in town or up on the lake?
Up on the lake. I rode the RSKT, you know, my bicycle trips. So I stayed there the first night.
Were they there?
Oh yeah.
Oh.
He picked
So,
me up. Yeah.
so you were with them, you're just like stay in their place.
No, not they.
So they moved across the street, now they're on the water.
They're right on the water. Really nice.
I say Christine, no, not.
Is Steve remodeling it? Or is it the way it is?
It's really pristine shape. They did a few things.
Oh yeah, but seriously,
He
so I
really
went
tore
from
up Susan's
Nicole
old house.
to Zoe there
Yeah, this one was
to Bastidio H. Cool. I don't know.
I wish my wife would bury her hatred. That would make life a lot easier for me.
I couldn't find the patient in the.
You ever socialize with Susan, Steve? No.
Because I went to look for it, and then I got like anywhere.
Yeah, it was like they had one of these
Ex-wife's sister.
MAs had to come.
Yeah, I know.
So,
I couldn't find it in the email.
it's only been, what, 15 years since they got married? It's like 15 years.
Yeah, that's enough time.
And then she's like, I don't want to do it.
So,
She's a nice lady, I don't care. But you know, when they hold these registers, they get in a fight and they have all these things.
So inside.
so your note before
My daughter said
today
that
that
she
you
was
wanted
going
to
to, I don't think that's going to forget Gina's drum in the break. Okay.
So like, the soccer,
Yeah. You just
High school, the residents of the fellowship, there's this that's the tipping point maybe.
Very much, Paul. Welcome.
I guess I remember one of the
Get through the guard dogs. Other than that, I'm good. If you're on Medicare Advantage, you have to make sure we're See, what it sounds is a lot of the local Medicare Advantage people are switching all their subspecialty care to everything other from Kaiser and these other companies. And they're trying to figure out why.
Thank you for letting me know you were available.
They haven't figured it out. They have this huge number.
I can do later this morning.
Anytime today.
No, it's like.
Missing money come out of the or is it usually
For November and then.
so if you want to transfer in.
She doesn't have Medicare, so she has. She doesn't have Medicare Advantage.
I mean, that was.
No, she's a MA.
that one was
I thought she was an Advantage.
You never texted.
She's a medical assistant.
Really? That's a standard.
Boeing or some other. They just won't pay for.
This is not Medicare Advantage. That's a whole other.
Good.
I'm sorry, Dan, I totally spaced that. So you're gonna make Steve introduce himself? Or is Drew gonna introduce himself?
I just worked on
Hit
that.
them with 2 exacerbations to kind of see people see how they do.
Nick, why don't we get started for the new faces or faces that don't know MNC? Tell us. Currently employed by Aimmune Research Center, and have been asked by Ron to talk about IgE-mediated food allergy treatment, the state of the art. Usually when people do disclosures, they just whip right through the slide, but I think it's really important that you get the disclosure here. The reason I'm employed at Asthma Inc. and not the Northwest Asthma and Allergy Center also, which is what I've done the last 18 years, is that I've accepted a job with a company called Aimmune Therapeutics in San Francisco. That doesn't start until the end of the year, so technically I'm not employed, so I can do CAD talks and whatnot, but I am a consultant in a way And you can see the rest of the disclosures as you have before you.
Does that mean you're leaving the first of the year?
Yeah, I'm sorry I haven't run into you. Yeah, so I'll be working with Drew and Bill a lot, hopefully once a month or so as a volunteer. But I'll be a full-time employee as a senior director at Aimmune starting at the end of the year. So so it's a big transition for me, but it's good timing for about 20 reasons. Not the least of which is I'm getting old, and it's going to have another push left in me, hopefully. But today, let's talk about what I've been assigned. And I'm going to focus primarily on clinical studies, which is what I've done for a long time. And I haven't done all the studies, or have participated in all the studies that we'll be reviewing, but I want to, there's some really important take-homes that you may not get in other venues. We'll be focusing initially and primarily on the what I think is pretty exciting time here in the next year, where there'll be, if all goes well, 2 FDA-approved products for peanut allergy, immunotherapy products, which we'll review. And then I call that the first wave of treatment, because neither one is perfect, neither one is a cure, but they're way better than what we've been telling patients for the last 25 years as the epidemic has exploded, which is we don't have anything for you other than a rapidly increased price of an auto-injector. Anyway, and then we'll talk about next wave treatments, and since this talk a couple of years ago, there's been a lot added to that list. Many of the things we'll talk about don't have data yet, but we'll talk about study design and what's out there so you can learn more. This is sort of a filler slide just to sort of remind us of the relative contribution of various food allergies. As you may know, many patients have multiple food allergies, and this is a little bit misleading. Peanut, the mouse works. Oh yeah, okay. So we got peanut and tree nut often in the same patients, and then of course milk and egg, which the vast majority of patients outgrow that. As you can see, the peanut is a big one, and if you did a search on clinicaltrial.gov, you'd see that peanut has disproportionately been the focus of the clinical trials over the years by a factor of 3 or 4 over the next most commonly studied in terms of treatments. And I guess for good reason, although it bothers me a little bit because most of the patients in the phase 3 trials have allergies to other foods also. So we're hoping that there's a multi-food answer down the road. Rather than bore you with a lot of epidemiological slides that are well validated and you've probably seen 100 times, let me just plug Dan Petroni's data mining of our EMR at Northwest Asthma and Allergy Center. So this is the part of EMR that makes me smile, and it's really a pleasure to have. It's the data input in clinic that is less pleasant, but I won't go there. This is, as you may not know, we invested in EMR in 2006, and so it's been a long time, and so there's a lot of data in there. And what Dan and I did was establish, okay, what are the food allergy diagnosis codes for office visits, and just quantify them. And as you can see in red, there's a huge increase over that 11-year period in our practice, and 12,000 in the past, in 2017, 12,000 visits in the practice. So this is pretty much dominated the landscape, and in my opinion, it's been the number one unmet need in the specialty for at least 5 years. And the reason why even though we're called Asthma Inc., 80% of our business is food allergy, and Dan's brainstorming about new names, and if anybody has some bright ideas for our research center, we're happy to entertain them. Now, another important baseline thing is to understand, or at least discuss and really point out what the peanut allergy unmet need is. It's different than you might guess. Peanut butter sandwich consumption is not what these patients or their families want. These patients don't want to do that. In fact, that's a problem sometimes with oral immunotherapy, even though they're having no symptoms and have been successfully desensitized, they don't want to eat it. And it depends on, we get biased because we see the ones that are having trouble, but it's a subset, probably a minority, but nevertheless a significant minority that don't want to eat it, even though they're desensitized already. So it is not something that we worry about. Eating Reese's Pieces, peanut butter cup. If I weren't old and overweight, I'd be doing that because I love them, but that's not what our peanut allergy patients want. What about death from accidental ingestion? This is absolutely an unmet need, and it's always a tragic event. In fact, we learn about almost every tragic example of this in the country. So it's hard, though, to focus on this as the primary unmet need phenomenon because, statistically speaking, it's 100 times more likely that a peanut allergic patient will die in a car accident than from peanut allergy. So without belittling that, we have good support, and I think, to keep it in context. And so focusing just on mortality is not what is driving patients to our clinic. Rather, the morbidity associated with concern, fear, anxiety, however you want to characterize it, and this has been the subject of scores of studies over the years. Peanut allergic families, they are turned upside down. I mean, and it's independent of education level, whether the parents are anxious or not, it's still a big deal, and why we see them in our practices so often, and why it's so important to keep focusing on helping. All right, so let's transition to food allergy treatment. And we're going to fast forward to phase 3 because this is what we call the pivotal trial period. And there's actually 2 different products in this category. The first is called epicutaneous immunotherapy to peanut. And that trade name is Viaskin for the technology, which we'll talk about a bit more. It's a company in France called DUD Technologies. And there are 2 phase 3 studies. The main pivotal trial for efficacy was called Capiz. Over 350 children ages 4 to 11, so huge. I mean, it's hard to overestimate the difference between the size of these pivotal trials and these pilot trials that get done either in early phase or by investigator-initiated studies, for example. And then a safety study called Realize with almost 400 patients. The oral immunotherapy product called AR101, the trade name isn't available yet, by a company in Aimmune Therapeutics in just south of San Francisco, which is the company that I'm going to be working for. Palisade is the name of the phase 3 trial for efficacy and safety, almost 500 patients, and RAMS is the safety only. As you can see, these are parallel sort of numbers of patients and targets for both efficacy and then additional safety data. And it's not coincidence that the FDA was very careful about directing the companies to do this. And on the basis of the fast track and breakthrough therapy and acknowledging the unmet need, the FDA awarded that designation, which should make it the hurdles a little easier to get approved than otherwise. So what is a patch? I mean, this is really important if you've not seen it before. You can conceptualize it. It's really easy to think about, but it's a fairly sophisticated intervention where there's actually a round circle that has, even though it's a patch, so it's fairly flat, there's actually some distance between the skin and the equivalent of tegaderm above it. And the protein is on that sort of tegaderm-like layer, and then there's natural moisture that comes up from the skin and condenses, and 100% of that protein is absorbed into the skin over their 24 hours that the patch is on. So it's a pretty effective method of getting beyond the outside and under the skin. And it takes advantage of the fact that the basement membrane prevents it from getting into the general sort of systemic circulation, and it sits there. And the Langerhans cells have access to it and very sort of carefully bring it into back to the lymph nodes, presumably, and that's how it exerts its effect. So it's actually a pretty nice story that has some decent validation behind it. Switching to oral immunotherapy, there's a lot more in the literature on this, and I just want to, this is obviously a busy slide, but it speaks to the not just peanut. There are milk and multi-food studies in there as well. In the far right, you can see that the primary outcome has these huge numbers, and same with this third column data, or the third from the right, which is the maintenance dose. So you can see the maintenance doses are 1,000, 1,800, 3,000, 5,000, so 5 grams in some cases. So it's a lot of protein that they're consuming each day. I mean, in our specialty, the concept of immunotherapy is the highest dose that's tolerated should work the best. I mean, that's how we do subcutaneous immunotherapy, and if we use the how well the patient tolerates it as the index of when to back off and what we consider the appropriate maintenance. And that was sort of initially pursued with food. One other one I want to point out is the Wasserman study. So that's in 2014. I don't know if this cursor is working or not, but anyway, so it's the fourth one from the bottom, and that was 352 patients. It was not a validated protocol. It's basically a real-world clinical experience by the patient, the allergy specialists among us that actually do this out of their practices off-label. So we call that early adopters. I mean, there's other ways of characterizing them. I, for those of you that have been around a while, debated Jim Baker from Oregon about, I don't know, it was 10 years ago or something, and I was taking the con position that this is not appropriate for clinical practice, and he has been doing it for like 15 or 20 years and took the pro. So they are pioneers at the same time in a way that made some of us nervous in the beginning. Anyway, but it was important to see that they've had a 10% sort of incidence requiring epinephrine to treat patients, but still felt it was very acceptable, and patients were happy, and they were happy, and it was sort of kind of like what we were used to in clinical practice with subcutaneous immunotherapy, where allergists know how to deal with this, even though it's importantly different in some ways. Anyway, well, let's move back to the AR101 and what's called coded, which is a standardized protocol for administering this and updosing, and including the process of how you get educated for staff members and doctors to do it. And it's a standardized approach, as I mentioned. There's 3 phases. The first phase is on the first day, which is in this initial escalation, starting with 0.5 milligrams and going up to 6 milligrams over several hours. Then the patient comes back by protocol the next day. In the real world, it could be within several days of getting their first dose that they're going to end up taking at home, which is generally 3 milligrams. Now, that threshold is below the threshold for 95% plus of patients that even have life-threatening peanut allergy. It's not typically going to cause problems, but to err on the side of safety, starting at a half a milligram was how it was engineered. So presumably that first initial escalation will be a boring day in most cases. Then there's an updosing phase, which is the familiar concept for immunotherapists like us, but different in terms of food. So that patients will go home on that 3 milligrams, and 2 weeks later come back and get the next dose. And it takes about 6 months of every 2 weeks dosing in the allergist's office to get to the final target, which is 300 milligrams, which is almost tenfold lower than many of the studies in the literature that I shared the slide before. So a pretty modest target for maintenance. And then the third phase is the maintenance phase, where they just come whenever they would have come to the office visit anyway, just continue taking it at home. So that's the procedure anyway with oral immunotherapy. Well, let's talk about the trials. And I think the primary outcomes are really important in this field, and it's extremely confusing. And that's why I want to take a little bit of time. Both products' phase 3 studies have been submitted to journals and been reviewed and then sent back been revised. So hopefully you'll have in print in the next 2 or 3 months the real sort of valid peer-reviewed publications on this. But for the time being, we're kind of limited to what I could get off clinicaltrials.gov because of the confidentiality stuff. So the entry criterion for the studies in terms of how does a patient qualify in the inclusion. And there's a lot of semantics. So eliciting dose of less than 300 milligrams of human protein was the patch phase 3 study. So that means that they had objective symptoms at that dose or less in order to make it in. The parlance that's used most of the time now is highest tolerated dose. So an eliciting dose of 300, the way these scales work is a tolerated dose of 300, meaning that the investigator felt at the bedside that it was okay to go to the next dose. So it goes from, in these challenges, it goes from 100 to 300. And I think I've got that in one of the slides coming up. And in the oral immunotherapy trials, the dose-limiting symptoms were at less than or equal to 100, or the highest tolerated dose was more, they couldn't have been more than 30 milligrams. So they had fundamentally different entry criteria during the double-blind placebo-controlled trials at the start of treatment. Does that make sense? It's a little confusing. Yeah.
Two questions. One is, how did they pick the 300 milligram dose, and how many people crash if you tolerate 300 and then you advance them beyond that?
Oh, I see what you mean. So, well, I mean, there was both studies. We've gotten comfortable with this finally after hundreds of patients going through it. You go past that tolerated dose, the eliciting dose. It could be 3 hives and they get better with cetirizine. It could be wheezing, swelling, cramping, abdominal pain, needing 2 injections of epinephrine and with an IV. Not usually, I don't think you've ever had to use the IV for fluids, maybe once or twice out of several hundred, but these are all done at either Children's Hospital, or for these studies at Children's Hospital, and then for our adult studies at the UW Medical Center, CRC. So it is serious business and during the challenges, and that's why, even though most of us do challenges in our satellite offices, we do low-risk challenges in our satellite offices. These are high-risk because they're trying to get into the study, so we wouldn't even be there if we thought they weren't allergic to peanut. And you can't just look at somebody and know what's going to happen when you get to cross over that threshold. But generally, it's not unlike shot reactions in our offices in terms of, okay, don't be afraid to use epinephrine. I mean, it aborts it really quickly. And there's actually a international difference in style where you look at the reactions in the sites for these studies that were in Europe versus here, and they were much less likely to use epinephrine. And then when they did use epinephrine, they were much more likely to require more than 1 dose of epinephrine. So I think the stereotype is the American allergists use it as a tool that shouldn't be judged as an index of horribleness. I mean, it's just, let's not take a chance. Is sort of how we think of it. But that's, again, oral challenges, not the actual adverse events to the study drug. And it'd be really nice, if we want to talk about this, we can when there's time, but the gold standard is that, the FDA won't let you do an efficacy pivotal trial without oral challenges because the surrogate for that are not good. But it's not that gold standard is that good either. I mean, we'll talk about that, but it's one thing I've learned, and Dan can chime in too, but it's been more skeptical of how wonderful this test is. It's great for yes, no, in terms of is it 5-fold, or 2-fold difference this year. It's really hard to know. It's sort of like a blood test in that respect. But anyway, sorry to get sidetracked. But and then the primary outcome with the patch trials were dependent on that eliciting dose. So if their eliciting dose was greater than 10 milligrams, which is the vast majority of the patients, it was greater than 10 milligrams, then they had to get to they wanted to get to at least tolerating 300 milligrams or an eliciting dose of 1,000 milligrams after a year of treatment. So that was their primary outcome for that. And then if it was much lower dose, then that caused the reaction at baseline, then they only had to get to 100 or 300 of eliciting dose. That makes sense. Whereas the OIT Palisade study, again, and it's slightly different because this went up to age 17, whereas the other one was only up to age 11. But the primary outcome is those who tolerate 600 milligrams. milligrams. In other words, during the month 12 challenge, they had 600 milligrams as part of their challenge, and then thought, okay, it's okay to go to the next dose. So those are completely different primary outcomes, but it was, so it's important to know that. And this is basically showing the classic Practal guideline oral challenge procedure. So, and then highlighting the difference between tolerated dose and reactive dose. So it usually goes up approximately threefold each time.
How high did they go with the doses in each of those?
Well, at baseline, it was only up to 300 milligrams because they'd be out if they didn't make it, if they didn't react. But they went, I think, so I know the Palisade OAT study went to 2,000, 2 grams, and they added the 600 milligram dose in the middle. So it went from 300 to 600 to 1,000 and then 2,000. And then I think Papiz just went the usual up to, they went to 2 grams also. So they both went to 2,000, but there was no 600 milligram step in the patch study. Now, if you think that's confusing, wait till you see the results here. And so the reason I'm doing this is because these are going to be out there, these data, and it's going to be apparently very confusing. Somebody that's done this a lot, I was totally confused. And maybe I still am. But I think it helps to get our arms around this and see what the peer-reviewed journals come up with their statisticians accepting it. So in order to keep it, and I don't think it's appropriate to compare as apples and apples these two studies because the study designs were different, but it just shows you that, for example, the group that had that EPIT A, the ones that had the low, the reaction at a lower dose, the baseline, whoops, this likes to jump around. The baseline dose was, as you see on the left, 3, and then they would qualify at month 12 with 100, tolerated, or 300, or 30 is the, or 1,000 is the eliciting dose. The others, it was baseline of 100 and 300. So they didn't have to get that high to meet the primary outcome, is the point, with the EPIT B. And yeah, Matt.
So you're showing these as examples of what would be a responder?
Yes, exactly. These are the sort of the ranges that the study design would accept as yes, this is a responder. Thanks for pointing that out. And so I think it's really important. And then what we can get from the press releases from DBV, which are public, the actual composite of those two categories was slanted much more towards the higher eliciting dose. And so that baseline in month 12 are very similar to EPIT B rather than EPIT A. Whereas on the Aimmune, the highest tolerated dose, so you could go that range that you see, the responders could be in that range. But then when they've actually published what their median tolerated dose was, and their median tolerated dose at baseline was only 3. So they reacted at 10 on average, median anyway. And then the median at month 12 was 1,000. So this is what's out there publicly now, and so it's completely different. I mean, and it's very confusing. But I think it's important for us to get our arms around that.
Do you have any sense why that is? That the second study had kids who had a much lower tolerated dose. That's what you're saying, right? That
You mean EPIT A and EPIT B?
well, no. In the OIT study, you're saying that most of the kids reacted at 3 milligrams. If I'm understanding right.
Yes. So the median at baseline, so it's a lot reacted right at 3, which is pretty sensitive.
Whereas I think in the EPIC composite, you're saying most kids reacted at 100.
Exactly.
But part of it is the entry criteria were higher for EPIT, right? Weren't they 300 versus 100? So you would expect the median to be a little higher.
There's also objective criteria in the OIT study. So DBV's was very, very strict. Had to be straight up objective. So abdominal symptoms, you could have the most severest abdominal pain, but if you don't have a hive and you don't throw up, you don't qualify.
And they would almost, the parent would shoot you if you didn't go to the next dose, believe it or not, even though they were miserable. So they didn't want to be out of the study.
But in the Aimmune trial, they did allow subjective criteria to capture it. So some of the kids would have been captured lower in the DBV. I found more severe reaction in the DBV study because of
it's
the
really
force to go up.
And I'm spending so much time on this because it's the gold standard, and the gold standard needs to be more standard. Yeah. I mean, it's not a great, and actually in the milk study, it was very similar in terms of their difficulty with that. So you would think the more objective criteria would be more accurate, and the fact is that the data didn't, as you'll see, didn't play out as crisply with that. Ironically, I was shocked, actually. Anyway, so what about the primary outcome results, which have been shared publicly? So and this is all intention to treat, which is important. So the patients that dropped out for whatever reason still get included in the analysis. And with EPID, they had 35% had a treatment response, so it was a responder based on their criteria compared to 13% on placebo. And with OIT, 67% had a treatment response compared to 4% of placebo. Now, what's really important is the statistics here. So I learned a few things trying to research this. We're used to seeing, the 0.05 or whatever, and the more zeros before the number, the better. Well, it turns out that some journals don't allow you to be more than 2 or 3 zeros, and so with the Palisade one, there was something like 30 zeros, but both of them had a lot of zeros. What's interesting though is the lower bound of the confidence intervals were completely different. So the confidence interval is sort of an index of likelihood that this wasn't just a random occurrence, and there's a pre-specified lower limit, so you want to be above that pre-specified limit, and with DBV it was, the FDA mandated both of them to be 15% lower bound, and DBV's was below that, which was a bummer, but the good news is, and I'll show you the quote on their website, is they've talked with the FDA, and the FDA is willing to continue going forward with it, so we're not sure what that means in terms of whether there's subgroups that they're going to be happier with, or whether they're just going to approve the whole thing. I don't know, but it technically didn't need that, and it's an important point, even though most of us are not used to thinking about it.
So, if I'm understanding, it seems pretty clear the OIT study sounds like it had more severe kids enrolled and clearly had a much greater response, right? Is that a fair assessment?
Yeah, I mean, with the caveat that they weren't apples and apples. The outcomes were different that they were looking at too, but it was, and then we're going to come to a more practical summary of, because I think this is a great pro-con, because even Dean can prove it, because neither one's perfect, and they're for different reasons.
I wouldn't say more severe because the entry criteria was different. So the entry criteria for the Aimmune study was different than the epicutaneous. So,
but in general, they reacted at lower doses.
Yeah, so some of the other kids could have, in the DBV study, could have been under that criteria lower.
Right.
But because of the objective, because of the mandate of it, we had to go higher and push them harder to do it.
Yeah, one thing that, just as an example to illustrate what Dan's saying, surface symptoms and why I think tolerated dose is okay to talk about is, like, a lot of patients will get like mouth itching or even a sense of throat swelling, and even though that's supposed to scare us, that's never really swelling. We've not seen that as a problem. So and then they go 3 or 4 more doses before there's another symptom, or before the symptom changes. So it is kind of an interesting, again, illustrating the gold standard flaw is that it's not just as quantitative as we'd like to make it sound. Very good question.
Well, I was just going to say the same thing as Dan, is that with the OIT study, a lot of patients didn't react to that lower dose, but they could have reacted, their threshold may have been higher for whatever reason that particular day even, and they could have had anaphylaxis at 150. So they're not necessarily,
It's hard to judge severity.
You can't judge severity based on when they had their reaction.
Sure. But in terms of study design, it'd be better to have those results just because it matches. So they're whether they got lucky or what, it was just different. Anyway, so moving on. Now, off their website, this is sort of the language that's been used by DBV after their discussion with the FDA about that. And it talks about the lower bound of the confidence interval not being met, but they have discussions with the FDA. More importantly, the safety data, and this is another big take home, is generally the patch is really safe. As I mentioned, it doesn't get below the basement membrane. They did actually have several cases of anaphylaxis, but we think those were outliers, and we're not sure what happened with those. But they just reported this way. The vast majority of cases side effects were local, transient. In other words, they tend to subside over time. In the phase 2 studies, they got better in the second and third year. We're almost gone. So it's like the body appears to get used to it in general. And the discontinuation overall in the whole study was only 10%, which is pretty good. And it was equal in placebo and the active treatment arms. And only 1.1% dropout due to adverse events that were felt to be due to treatment. And the adherence was more than 95%. So there's important practicality take-homes with that it's patches easier and better tolerated. Okay, so what about the oh good, that does show up. The data from phase 3 that's on the website for AR101 or in the press release. Well, it turns out, so this middle column that I think, I can see it or not, you see the arrow, you see that arrow? Okay, just to take my word, the upper middle column, 600 milligrams, that was the primary outcome, and you can see the statistics there. But it turns out at 300 milligrams, so 67% responded at the 600, half tolerated 1,000 milligrams. Okay, so this is meant to illustrate that the dogma for what the optimal dose in OIT is changing. It used to be bigger is better, 5 grams is awesome if they can choke it down. Well, no, not necessarily. 300 milligrams is pretty darn good, even after a year. I mean, who knows after 2 or 3 years whether it's better. So half of them tolerated the equivalent of 4 peanuts after 12 months, or 6 months of maintenance, which is the way the study was. So, and then down completer. So normally we don't talk about per protocol as a way to say it works or not. But this is relevant because completers, meaning they made it to maintenance and we're tolerating it, is sort of what's going to happen in practice, presumably. That if you're on 300 milligrams and eating it every day, then the chance of having an adverse reaction in a restaurant to less than 300 milligrams is hard to imagine. So that's the point with this reporting a completer analysis here.
So is that a large difference due to dropout, largely? Like the fact that intention to treat is 76.
Oh yeah, absolutely. And that's the bad news because the OIT is not all good news. It's the bad news is and we'll come to this, a fixed subset that don't tolerate it. And it's not anaphylaxis. Typically it's GI side effects and they need to be off of it, is the bottom line. At least off of it based on a Q2 week advance. It's possible. And if you talk to some of these pioneers out there, our colleagues that have been doing this a long time, they can a lot of them speak to, staying at a very low dose for 3 months or something, and then doing low and slow. Like we've done that with sulfa and other there's other examples of that where you can do immunotherapy with different, especially when it's not all IgE-mediated. Anyway, so no deaths, thankfully. The serious adverse events were low, and about 1.1% experienced an SAE possibly related to the treatment itself. It's hard to know. As Mary pointed out, there's cofactors that can make a reaction on a given day more or less likely, and some of those are predictable. We'll come back to it. One patient did have severe anaphylaxis and had to be dropped from the study, had part 2 injections of epinephrine. But no, really bad, no actual cardiovascular symptoms. Most patients didn't get investigator-reported systemic reactions. This is a little misleading, though, and I'm going to, even though it's not on the website, I'm going to say, majority of patients have GI symptoms at some point with this treatment, so it's not innocuous. But the majority also make it to maintenance without symptoms. So they may have had GI symptoms transiently. But it's a mixed bag, and that's why I think as practitioners we have to know that going in, and the patients and the parents would need to know that going in as well, and it's in our practices. And it's typically either nausea, heartburn, or abdominal pain. It starts within an hour of the dose. It may last a half hour, an hour, or 2 hours, or not. The protocol required that you not prophylax with any H1 or H2 blockers. So it was in order to not sugarcoat what was happening. Obviously, there's things you can do in real life to mitigate them sometimes. But the last thing we want to do is cause EOE and be in denial long enough for it to do some damage. There was one case of EOE out of the 500 plus that were enrolled, and actually the 1,000 plus that have now been on active drug. You might say, that's really low. And in fact, it's less than what's reported in the literature. But the point is that if you stop it, there's predefined criteria for stopping the treatment. Even if we think that there's a continuum, and if you keep on it, the EOE would probably be out there. But if you stop it, it tends to resolve. So I mean, typically, most patients don't get scoped because their symptoms go away. So anyway. All right, and this is a recent paper that Dan and I wrote that talks about advantages and disadvantages of the AR101 and Viaskin Peanut. And I've highlighted, well, let's just talk about, the main advantage of the Viaskin is that systemic side effects are rare and there's no updosing visits. Small exposures to peanut in the responders, which it's likely helpful. So, I mean, most of us in this field believe it really works. The question is, in whom is it working? There's definitely a subset that doesn't work. And that's the downside. A third of subjects in the phase 3 study had no benefit in the first year. Phase 2, which optimal dose was 28 patients in phase 2 of EPIT, a higher proportion it worked after 24 months, and then even higher proportion it worked at 36 months. Small number of patients, and so we need to see if that's generalizable later. But that was phase 2, the other downside is in an individual patient you don't know if it's worked at all unless you do an oral challenge. And as we're talking about, would you judge that a high risk oral challenge or not after they've been on the patch? I mean, it's a tough one. Dan's got to struggle with that in our clinic because sending them all to children's every time is a daunting prospect. Okay. What about AR101? The main advantage is that the majority of patients do reach the maintenance pretty easily and are tolerating it without side effects. There's 15 or 20% that don't. And then there's another portion that is sort of nebulous, that's anecdotal, but I think it's important to share, which is that they don't like it. I mean, so it's I wouldn't say the majority, though. I've been systematically quizzing them after a year and a half or 2 years, and a lot of them, this is awesome, it's changed our life. And then there's some that say, he just doesn't want to do this anymore. Or I have to, it takes 45 minutes for them to choke down their nose. So these are just practical things that will be an issue. The main disadvantage is the GI side effects that, as I mentioned, 15 to 20% don't stay, and the small risk of EOE. All right. So what about practical considerations for the doctor? Well, there's with Viaskin Peanut, there's no specified interval of office visits, so it doesn't really change your frequency of seeing them. With the OIT, obviously, with the updosing visits, it needs to be a system, and if you're a solo practitioner in a satellite, it's a lot harder to vision, whereas in volume, it might be a lot easier to have this economy of scale with it. And I know that some of these guys and gals doing OIT in their practices now, that's what they do. They have 1 day a week where it's just, one practice that I talked with last week did 40 patients in the OIT practice in 1 day, updosing or initial escalation, because it's all the same. So it lends itself to a systematized program, a lot like the way we do subcutaneous immunotherapy. difference in the system, but in terms of the actual details are different, as you know. On call, okay, patients on OIT contact you once in a while, and Dan and I, they all have our cell phone number, and you get a text every so often. When I quiz the docs in practice doing this that have several hundred patients, they get a couple texts a week. But it's manageable if the patients are trained properly. But it's different. It's more than subcutaneous immunotherapy for sure. Ice cream peanut, you wouldn't really get calls. If you did, you'd be upset that they called you. And there's no reason for it. What about precautions? Is there some hassle at home, even if you're tolerating it, doing well? Well, yeah. I mean, the patch, not much. I mean, it could fall off while you're swimming. No big deal. You're at 250 micrograms. That's not going to hurt anybody. You just put on the full dose the next day, or even if they miss it for 3 or 4 days, you just put it on and it's fine. The local dermatitis is an issue for a lot of patients, and they need the topical corticosteroid to make that resolve. With the OIT, much more complicated. When the body temperature is elevated from exercise or exogenous heat, you have to avoid dosing. I mean, it's for protocols at 3 hours. And even, this is post-exercise, but dosing, then exercise is worse, so it elevates your body temperature while it's in your body. So you have to pick a time of day that works for the family, and you need to understand this. And then URIs change the threshold as well, so we usually cut the dose in half, or if it's really bad, then febrile, then might hold it a day or two. It's like a lot of things where you can stop it for a few days and then resume it. And there's an algorithm in terms of when you have to come back in for an observed dose. Anyway. Probably say, what about the immunology? Well, both products, this is, unfortunately, I just have phase 2 on this because of it's all that's publicly available. And let's just suffice it to say, in the interest of time, that both cause the expected increase short-term in specific IgE to peanut, and then after 12 months, it goes back to where it started, and then if you continue, it goes below baseline. That's what we expect with successful immunotherapy. With IgG4, which is another marker of efficacy, that will go up and stay up. And this, I'm surprised they use these graphs in their phase 2 data, but it shows that, but it shows all the doses, and phase 2 is a dose ranging thing. And then in the lower right, you can see that was the optimal dose, the 28 patients that were in that dose. So you can see the IgG4 actually went up impressively in that group, which is why they chose that dose in that age group. And this is the equivalent stuff for AR101, and just say they displayed both the specific IgE, the specific IgG4, and then the ratio, and they're both in the sort of direction consistent with other studies we've seen with different kinds of immunotherapy. Any more questions about these two, which we spent way more time than I thought I would on? It is kind of going to be our here in the next year.
Steve, on the age range, the Aimmune one, was it equally effective through the adolescents, whereas the epicutaneous, the adolescent study was not effective?
I can't show the slide, but I've seen the data. The Aimmune one, remember, Virginia Mason enrolled adults in this study. The primary outcome was focused, the primary analysis was just on up to age 17. But they did, and it's because they didn't have enough numbers, and they didn't power it to get the adults they wanted to see. And I think there was something like 40 adults or something in it. And then a lot more in the 12 to 17 group, and then the majority were in the under 11. They all had equal efficacy in all 3 groups. So it's not a pointless exercise in an adolescent, for example. Since I'm getting a little anecdotal here, I will say what I've heard about the DBV data too is it worked a lot better in 4 to 6-year-olds too, and which is cool if that's the case, and because it could end up being a stepwise treatment decision with products depending. But and both studies, or both sponsors are doing studies in toddlers now, phase 3. So they're going to go down to age 2, and so it could be that one or both is better as the immune system being more plastic in the younger age groups. But that's a long-winded answer. The short answer is it worked in the adolescents and adults as well, the oral, whereas the phase 2 with the patch didn't, is why they chose the 4 to 11 age group.
What is the actual product in the Aimmune? Are you sure the product?
Oh, yeah, I'm sorry. Yeah, so the product, I apologize for that. So it's, you might say, well, why don't you just go to get peanut butter or something? Well, it's a very carefully pharmaceutical grade peanut flour, basically. It's lightly roasted. It's exactly characterized for content of ARH 1, 2, and 3. So really tightly controlled. Apparently, there's a fair amount of variation in just at grocery stores and things. So it's that's what it is. It's
like a pill.
They're in capsules. The powder's in the capsule, and then it's in these little punch-out packets, kind of like a birth control pill, but bigger capsules. And then you take like today's capsule, and then you break it open over some applesauce or over chocolate pudding or some other substrate. It's not real specific, but it has to be mixed. And so the feeling is that having it coat the GI tract on the way down is relevant, but it was flexible enough that it didn't specify the matrix. But yeah, it's a really good question. And once you get to maintenance, 300 milligrams is not a capsule, it's what they call a sachet, so it's an easier to open thing. So, but yeah, so this will be presumably a specialty pharmacy that would supply it. The practices will have their own samples to be able to go up and down, because the allergist will decide whether it's time to go up or not when they come in. For example, if their asthma's not doing well, they would not go up. So any other questions about this stuff? Well, let's just go quickly through the rest. There's not a lot of more data out there. There's a lot more study designs out there, though. So the SLIP trial, this is from the COFAR group, 40 subjects that Dave Fleischer was the primary author on. And they went up to, 496. The tolerated dose went from 3.5 milligrams to almost 500 milligrams in this study. Although when you see it, it's kind of all over the map. And this is a stepwise increase of dose with sublingual peanut protein, sort of analogous to OIT, but starting with lower doses, and it generally is safer than OIT. And however, the statistics and the conclusions from the COFAR group that it was a modest desensitization. I think most people would put the degree of efficacy to SLIP by itself, even at high doses, which is much different than a lot of the community docs are doing it. Well below the OIT and possibly equal or possibly a little bit stronger than the EPIT, depending on the patient, though it's hard to make real generalizations on that. But anyway, this is more of a baseline thing. This is what I think is really exciting. We don't have data on it, but it's a study that is a partnership between Sanofi and a Seattle company called Immune Design, that has a TLR4 agonist, which is basically the equivalent of a piece of gram-negative bacterial cell wall that is actually it's the innate immune system away from allergy. So it's an adjuvant that has been used in vaccines by Immune Design locally, and they've licensed it to be studied with peanut by Sanofi. And this is a phase 1 study that's now underway that is basically a sublingual protocol after treating with the GLA or the TLR4 agonist first. And then let's transition in the interest of time to the anti-IgE. Most of us know about omalizumab, but it turns out this is not new. In 2002, we were part of a study that led to a phase 2 study that led to a New England Journal article as standalone treatment. In other words, not with immunotherapy, but just anti-IgE infusions. And those results were promising, but due to a legal battle in the courts, that company stopped developing it. In 2005, Genentech used omalizumab, and that study was aborted due to an adverse event that occurred during a challenge, or a couple of them actually. And then Novartis, which also has omalizumab rights, but had a different, more high affinity monoclonal anti-IgE that they looked at, but the study ended up being canceled before it started because of arguments with the FDA about the substrate for challenges. So this is not new thoughts, is the point here. Interestingly, in the last month, Genentech has announced they're resuming an omalizumab program that's standalone treatment. So it'll be interesting after 18 years or whatever it's been that'll get going again by itself. More to the point and more practical for us is using omalizumab as an adjuvant. Okay, so there's a lot of data. This is just a summary slide of the 10 or so studies that are already published on this. Variety of different foods, variety of size studies. And it's in a nutshell, sort of, pardon the pun, but let's talk about one more recently published one, I believe from Stanford, that illustrates what is so helpful about omalizumab when you're doing OIT. So this was 37 subjects. Their idea is to be on the treatment for 12 weeks, the subcutaneous injections, and then do an initial escalation. Remember, the initial escalation for the AR-101 goes to 6 milligrams. Okay? The initial escalation after Xolair goes to 250 milligrams. All right, so look at this in the interest of time. Just look at the graph here. That's the number of patients that actually made it to 250 after that 12 weeks is on the left side there versus placebo. So it's pretty reliable, and this has been anecdotally, Dan and my experience with the study we were involved with, the multi-food one with omalizumab. It's a nice bridge to being able to tolerate pretty close to what Aimmune is considered a maintenance dose. This is the first day, okay, and then they go home on that dose. So it's an interesting phenomenon. And then this is just showing the immunologic effects, which are slightly different than immunotherapy by itself because the omalizumab affects the receptors on mast cells and whatnot. So the skin test reactivity does diminish. Specific IgE does go up. And so that's what we've seen with a variety of immunotherapy studies with omalizumab, even with respiratory allergy. What about probiotic in immunotherapy? I mean, you may have seen the Lancet publication in the last 3 or 4 months that actually it says 2017. So time just flies. So this must have been 10 months ago or something. But anyway, there was a study in Australia where they used probiotic at very high dose with oral immunotherapy 4 years earlier, and for 18 months, and then stopped the immunotherapy, and most stopped the probiotics. And then they just restudied them with challenges and skin tests and whatnot. And actually, the group that had been treated with the OIT and probiotic had smaller skin test wheels compared with the people that had been on placebo. And a lot of them came back, so the vast majority were back 4 years later to be assessed. And then they had the higher IgG4 to IgE ratios and more likely to tolerate an 8-gram peanut challenge, as you can imagine. So it was pretty interesting, made all the national news. It was not hard science, I would say, because it wasn't really controlled very well, but it was interesting. Okay, what about anti-IL-33? You guys know what that is. It's a sort of upstream in the cascade of activation of the sort of the type 2 immune system, and including mast cells, actually. So it has direct effect on mast cells, so it doesn't take a long time for it to work. And we were part of a phase 2A study that was done earlier in the year, and it was only the primary outcome was measured at 2 weeks after the injection or infusion of this stuff. So there are 20 participants, single-blind oral food challenge. The result really hasn't been reported publicly, so we're not sure what's going on. They are pursuing this with atopic dermatitis and asthma and chronic rhinosinusitis with nasal polyps. So to be continued, but there's several other bigger companies that have similar molecules, so that as a target isn't being forgotten. But I don't have any more data to share with you. What's very interesting is OIT plus dupilumab, which again I can't share the protocol, but that's a partnership between Regeneron and Aimmune, the targeting the common subunit of IL-4 and IL-13. And the hope is that this will make immunotherapy more durable and possibly more efficacious as well. This is a very interesting study from Stanford that I found in clinicaltrials.gov, a phase 2 single center, 3 allergen multi-OIT, one of which has to be peanut. And they have different, we'll go right down to the ABCD and the 4 cohorts. So it's 8 weeks of omalizumab followed by additional omalizumab, or 8 weeks of omalizumab switching then to dupilumab. And then dupilumab for the whole time is an arm, or placebo for the whole time. And it's actually the B and C and D, the switching to dupilumab, which is what it's powered to show. So it'll be very interesting to see if this it has advantages over omalizumab alone. The limitation that we think with omalizumab, it has no long-term effect. It only is effective while you're taking it, and it works great as a bridge, but it doesn't really cause you to have sustained unresponsiveness. And it's not clear that it increases or decreases long-term GI side effects if they weren't going to tolerate it in the first place. Lastly, in the last 1 minute, this is another phase 1 study. It's a single-valent, a multivalent peanut lysosomal associated membrane protein. It's actually a plasmid vaccine that causes internal sort of intracellular production of the protein, and then presents the protein on the surface in context of MHC class 2 without it entering the circulation. And at least that's the theory with it. And we're getting close to the end of phase 1. We were a site with this and haven't had any significant adverse reactions. It is subcutaneous, intradermal, and then there's after the last phase of it, the last cohort will be intramuscular at a higher dose. So far so good with that one. Still no data to report though, and there's more on this. And then finally the HAL allergy, so coming back to subcutaneous peanut immunotherapy, but this time using this aluminum hydroxide absorbed peanut extract like the Allergy, subcutaneous administration. Again, parenteral administration of peanut is a scary thought for many of us, and there are a huge number of safeguards in this study to make sure that it's as safe as possible. The idea is, and it goes all the way to 375 micrograms, which is a lot for parenteral administration. Each dose has a 4-hour observation. So no data to share with you yet, but the preclinical data was impressive, and they've had a good success rate with the other allergens that they've tried. So I believe that's the last slide. Sorry for talking so much.
At the end of the 2 studies you showed us in the beginning, the cutaneous and oral. So what happens to those kids when they complete enrollment or complete the study? Are they continued?
Yeah, so it's interesting. For phase 3, both sponsors have made it open label extensions and committed to having it available they're on the market. With the phase 2, the patch was not available after the 3rd year, and so we had a dilemma of like, okay, we had challenge data on them. What do you do? And we felt that it was unethical not to allow them to go on oral at that point. So if they tolerated 500 milligrams in their month 24 challenge, and then had no treatment after that, we would put them on, say, 300 or 200 or 150 milligrams of peanut a day at home, just using store-bought peanut.
Is that the ultimate plan with these, that eventually you just go on to?
It's a really good question. Hopefully, because I think with OIT, it's like a pharmaceutical grade. If they're desensitized, it's hard to imagine that that's necessary. That needs to be studied more because our anecdotal experience has been not as rewarding. It's not as encouraging as I would have expected. A lot of them started having more side effects once they switched, albeit because the parents were more inclined to want to go to higher doses at that point. So that may have been a confounder. But yeah, I think after a year or two of for example, this AR101 switching to peanut M&M or whatever might be fine. It's hard to know.
And then is there any data as to tolerance versus desensitization? If they stop eating for a
Yeah,
month,
so that's a difficult question. We do know that there's some data suggesting tolerance after several years in a subset. But clearly, they don't want the phase 3 they're not gonna claim it. It's all desensitization. The idea is that you have to stay on it. Again, we're immunotherapists. We know that after 3 to 5 years of subcutaneous immunotherapy to pollens, the majority is sustained when you stop it. Venom, similar, and so whether that holds true with food remains to be seen, but certainly following skin tests regularly while they're on it. And if the skin tests turn negative, then most of us feel like that buys you a lot of time, so you can stop it and then repeat skin test, 6 months later, and make sure it's still negative. But skin tests are still pretty predictive. Yeah.
Steve, are they keeping track of, the people who come off the OIT and the patch or whatever, and then go on to regular peanut? Are they keeping track of those folks who then have troubles? Because, anecdotally, certainly the patients that I've seen, majority of them have had troubles and have stopped. Yeah. So, but right now that's not being captured, so the whole thing's looking a lot better than maybe reality.
Yeah, I mean, the one patient we shared that was horrible. Yeah. That one had gone up over 1 gram a day. So it was, and I talked to Brian Vickery about that patient as it was happening, and it was just too messy for them to capture in the database. So there needs to be surveillance of this to get more information on it. But as I said, anecdotally, the switching to store-bought food has not been as smooth sailing as one would have guessed. But talking to the people that do it in practice, the majority do great on store-bought food after a while. And again, it's not science; it's all anecdotal clinical experience. There's something there that I think is very valuable to us, but we have to take it for what it's worth. So anyway, it'll be if the FDA approves these, then I think most of us will feel like, okay, now we have tools. It's going to be some work to get this integrated into our practices, and then we have to use our own judgment about what's best as time goes on. Great, Paul. Thanks for coming.
Basically, much more done telling them to switch over to now I'm telling everybody to stay with it. They can choke it down to stay.
Dog is going to dictate this.
But even then, I got a kid that's DOE.
The EOE is a lot higher than.
Yeah, is that right?
They're also in their first year. They said nobody used maybe in their first year, but I got plenty of people in their second year.
Yeah, well, it's a
guy that's my patient. His mom called me 3 times. He dropped out.
That's Aaron. That kid was on fire.
Oh, yeah.
And then one was exercise. One was cashew DOE. One was exercise with the dose. One I had
Probably not.
I think that's the one that pushed him over there.
Well, Aaron argued that kid was so tough. Like I had to really actually talk him out to his work. I was like, I can handle this. Well, that's the thing.
So that's why
Yeah, that's
not the answer. Yeah, so I also now tomorrow.
I think 25
my daughter just started.
So, yeah, I think it's that's why yeah, I mean,
2 years, and we're
I wanted to take It'd be like inhaled steroid.
yes.
You know Kevin?
Oh, I do.
She's taken over for Nicole. So I thought she'd come by and say, listen,
Yeah, sure.
because Nicole's leaving. Did you hear that?
No.
She's going to the old lake shore.
Probably closer to home.
Yeah, I think it's less complicated. Fewer cats to herd, probably.
She was ready to give up the species.
But
Yeah, I can't imagine doing it. It's too much going on.
Well, I can do
He's already been spread thin.
it's too bad Drew isn't here.
Oh, that's right. He had to go to clinic.
How long have you been doing that?
Oh, right,
Looking forward to meeting
And so-
everybody on AI.
I'm Mary. Mary? Very good. Oh, nice to meet you too.
I should have plugged Drew as the first author on the phase 2.
No, I saw him.
Vibes trial, yeah.
You showed his data, I can say. I can send him a text
great.
and say.
Yeah, it'll be good. Both the phase 3 study.
No,
will
way to
be
make
in
it
clinical.
happen. So, good. Well, I'm so happy to
Yeah,
meet you.
you'll get to work. You'll get to work together.
So now, where are you? I will email you. Yeah. I'm in immunology.
So with Susan.
With Suzanne.
Suzanne,
Yeah,
okay.
yeah. Right, I'm in that group, yeah.
I know that they needed somebody else.
I know. Well, it's tough being like a world-class place. It's like all-encompassing. It's hard to, because for a while they wanted to start, I gotta look more.
and no, I didn't have
Well, you
Same people.
somebody.
So it'd just be like a kind of well, yeah, then we'll.
They don't really.
No,
Immune deficiency in the food
they're
allergy.
different animals.
Different animals. Both about, immunity, but that's about the only that's a common.
Yeah, I came from UT Southwestern. Yeah, so our division there.